Wait for another 5 minutes, ma'am, because
Okay, okay, ठीक, okay. Smita, did the major sir revert back?
no, ma'am. I called him twice.
Okay. Abhishek sir, what do you suggest?
I think we can start because we are running short of time. No, I mean it's already 5 minutes
Yeah,
to the webinar.
yeah. I think we can start.
Yeah.
Yes.
So, good evening, everyone, and thank you for joining us in this IA and Geriatric Neurology subsection meeting. And today we have a very interesting case presentation by Dr. Anand Sharma, who is currently pursuing his senior residency in neurology in BHU. And Asmita, can you please share the CV? We have two very experienced moderators. One is Dr. Abhishek Pathak, my dear senior from AIMS New Delhi, and currently he is the head of the Department of Neurology Department at the Banaras Hindu University, IMS. And he has several credits to uh, his name, and he has several funded projects as principal investigator under various government body funding, and he has also got a lot of awards, and he is fellow from the American College of Neurosonology, and he is a visiting fellow at the University of Pittsburgh, and he has received the prestigious Peter Schiller Award from the St. John's Medical College, Bangalore, and he has more than 100 publications in indexed international journals and national journals, and recently he has become a qualified sleep expert as well. And moving on, we have Dr. Chamanjot Kaur from PGA Chandigarh. She is a assistant professor over there, and she has expertise in stroke management and neurocritical care. And she has special interest in epilepsy, movement disorder, migraines, and other clinical neurology branches as well. So, without much further ado, let us move on. And Dr. Anand, the floor is all yours.
Yeah, thank you so much. Good evening, respected seniors and consultants. The topic of today's discussion is a very important and a very good case, which has a very important message for all of us. The patient was a 60-year-old gentleman. He was a resident of Sultanpur. He was a farmer by occupation, presented to us with total duration of illness being 4 months, presented to us as the complaints of behavioral changes since almost about 4 months, with next complaint of forgetfulness, along with visual hallucinations of about 3 months duration, headache for a duration of about a month, and fever which lasted for only a duration of 10 days, and it was about 1 month back from admission. So this slide summarizes the timeline of illness. It started all together with the behavioral changes in the form, which was told by his wife to us as the decreased interaction with the family members. Although he was a very jolly person by nature, he always used to help his neighbors, his fellows, his colleagues along with his work. And he has suddenly started having decreased interaction with all of them, with more of surrounded by himself. He stopped asking for food. Only when asked for food, he would take food, and then he would have poor personal hygiene. Unless spoken to, he would hardly be speaking, only in few words, and then would be keeping quiet. And this was although very odd for the family members, but they thought that he could be having some personal issues, so not much attention was paid towards it. The next complaint was almost of a similar duration with started with forgetfulness. He started having forgetfulness for the only specifically for the recently learned events. For example, like where he had kept his money, where he had kept his belongings, especially the keys of the bike. With the recent conversations he had with the family members and the loan givers, he had the conversations. He started forgetting that the last meal which he had taken, he characteristically forgot most of the times that. And the only thing which told by the wife to us was it all of these complaints were improved on queuing. So whenever he was receiving hints, he would remember all of the things all of a sudden, and sometimes he would laugh at himself that he made such a silly thing and he forgot these things. The next complaint was visual hallucinations. It was very well formed in the form of seeing snakes, insects, and being surrounded by the crowd. It would although occur intermittently without any diurnal variation or without any specific time of the day, and but it was not associated with any auditory hallucinations. The next complaint was he had altered sleep pattern with almost the similar duration as the other complaints, which was told by his wife as he would prefer sleeping throughout the day, which was very odd for her. He would keep awaken at the night, and sometimes he would have fragmented sleep. But most of the days he would be sleeping in his room, and he would specifically wake up only during the meals. And later on asking why he's sleeping so much, he would say that he feels tired and does not feel like working anymore. However, she denies any REM behavior disorders. The next complaint was headache, which was told by the patient to his wife. It was holocranial. It was continuous throughout the day without associated diplopia, vomiting, or other signs of raised ICP, and it would relieve partially on taking over-the-counter medications and doing some massage. The thing which had brought the patient to hospital was the complaints of fever. It was for a duration of 10 days, which lasted 1 month back. It was acute onset, intermittent. Although it was not recorded initially, but the maximum reading was up to 100 degrees Fahrenheit, and it was having evening predilection with not associated with any upper GI, lower GI, urinary, or any respiratory complaints. So overall, the syndrome was a 60-year-old chronic kidney disease patient presented with subacute behavioral syndrome progressing into the encephalopathy. With no history of any recent travel, animal exposure. Since he was a farmer, we characteristically asked about the recent insecticide exposure, any history of drug intake, any dressing or navigation difficulty, with no history suggestive of any cranial nerve involvement, with no history suggestive of any cerebellar sensory involvement, no history suggestive of seizures, any myoclonus, anal limb phenomena, a history of any this autonomic involvement in the form of orthostatic dizziness, postprandial fullness, constipation, and urinary complaints, and no history was suggestive of any connective tissue disorder or vasculitis like illness. So moving on to the past history, he was a known hypertensive since about 5 years prior to the onset of symptoms, with initial poor compliance to treatment. And once he was diagnosed with chronic kidney disease, 2 years back, he started taking the medications properly. He initially needed the intermittent hemodialysis for 1.5 years before the onset of symptoms, but he stopped going for the dialysis in view that he would feel better without dialysis also, and he did not want to go to the hospital. And since last 6 months, he was not on any hemodialysis. Subsequently, he was being followed in nephrology, but 6 months back, he had lost to follow up also, with no history suggestive of diabetes, stroke, or any obstructive sleep apnea, with no history of recent blood transfusion as well. He was a vegetarian by diet with no history of any addictions. Family history, he was a fourth born male child of the family with no history of any consanguinity, with no history of any similar illness in the family members. So based on the history, the clinical localization was diffuse cerebral dysfunction with predominantly frontal, subcortical, and limbic kind of involvement, without any evidence of focal hemispheric, brainstem, cerebellar, or spinal cord involvement. The clinical anatomical correlations based on the symptoms were initially the patient had the complaints of behavioral syndrome in the form of apathy, reduced initiative, and poor self-care and self-hygiene, which was localized to frontal, subcortical, and executive network. The next complaint was formed visual hallucinations without any auditory involvement. It was localized to limbic temporal associative network, and especially retrieval kind of memory loss without any encoding involvement, which was localized to frontal executive network, and progressive encephalopathy, which involved the diffuse cerebral function, and headache probably localized to pain sensitive meningeal structure or the leptomeninges. Based on the history,
Dr.
based on
Chamanjot, would you like to come in? I mean, at this point of time, let's have a discussion. Maybe attendees, all those who are attending, they can come in. And Dr. Chamanjot, if you would like to comment on this, would you like us to
Yes, sir. Yes,
guide us
sir.
through?
Yes, sir. I think before going directly to the differential diagnosis, firstly, let's invite the listeners. What do they feel? What should be the differential diagnosis of this patient? I mean, if they can comment.
Comment or maybe drop in. If they don't want to speak, they can drop messages into the Dropbox, the message section, so that we can read. If there are none, I think Dr. Chaman, please guide us through.
Yes. So I think whenever we have any patient, especially elderly patient, with such a rapid progression in the cognitive decline, it is very important that we rule out certain important things. First of all, we know the patient is a known case of CKD. In some or the other sense, he is immunocompromised. We know that. And CKD is known to cause T cell dysfunction, neutrophilic dysfunction. So I think first and foremost, it's important to rule out any kind of infection. That comes a very important first differential. Subacute to chronic infections are to be ruled out in this patient. And we all have learned that we have a mnemonic called vitamins for learning for remembrance of rapidly progressive dementia patients. And even in that mnemonic, it is important how we place the sequence of these words. I mean, in such a patient, infections should be ruled out. We know he is immunocompromised. Second comes, since he is immunocompromised, he is CKD, systemic encephalopathies need to be ruled out. He was on dialysis also, so uremic encephalopathy becomes a very good possibility. Apart from this, since he is hypertensive, vascular causes become very, very important. We don't know if he's suffering from maybe multi infarct dementia or anything of that sort. Strategic infarcts might have happened. We don't know. So, when we don't have definite clues, we have to pick up these points from the history, so that in a dementia case, history is only going to help you. Examination might add on some other additional features, but if the history is correct, localization is correct, we are quite sure that our differentials are going to remain same even after examination. So I think for this, infections and a systemic encephalopathy become very important out of all the differentials for rapidly progressive dementia.
Yeah, Dr. Chamanjot, very pertinent points. And let us remind the listeners, I mean, rapidly progressive dementia is not the disease. It's obviously a syndrome where you urgently you need to have a sense of urgency in the way you investigate and how systematically you investigate, right? As you rightly pointed out, not all rapidly progressive dementia with hypertension, with maybe CKD, vascular dementia comes into a picture, right? So uncontrolled hypertension, patient having subtle strokes, rapidly deteriorating I mean, mental status. So obviously, people, the students or the, I mean, we start thinking of vascular dementia as a possibility. Obviously, it remains a strong possibility, but always remember it's not the only possibility. And gradually, you'll, as Dr. Chamanjot has pointed out, will reveal what all we did and what came out in patients. So always remember the mnemonic, as she told, vitamin, and you need to systematically and meticulously rule out all the possible causes, including autoimmune encephalitis. So let's move on to the differential slide. Dr. Anand.
Yes. So based on the history, we had kept the differential, the initial differential we kept as infective, since we know the patient had a chronic meningoencephalitis kind of a feature with subacute to chronic course of about 4 months duration. So first differential we kept as tuberculous meningitis. The points favoring were it was having subacute to chronic course with history of headache, recent low grade fever, although it was only for a period of 10 days, but the patient landed up in altered sensorium due to that. And the points against was fever was only for a period of 10 days without any constitutional symptoms like weight loss, night sweats, or any history of cranial nerve involvement. The second possibility we kept as a cryptococcal meningitis, since the patient was a known CKD and it is a relatively immunocompromised state, presented to us with headache, altered sensorium, and rapidly progressive cognitive decline. The points against were the patient was retronegative as per the initial investigations which he had brought to us, and with very short history of fever, with no history of any cranial nerve involvement. Third possibility in the infective, we had kept as slow viral disease like prion disease in the form of CJD, because the point favoring was rapidly progressive dementia with behavioral changes predominantly as in the form of apathy and hallucinations. The points against was headache and fever. They are very unusual in the slow viral disease, and the patient's wife denied any history of myoclonus, any seizures, cerebellar involvement, or any extrapyramidal involvement. The next we had kept as the neurosarcoidosis, as it is a great mimicker. It can mimic almost any chronic illness. But the points favoring was the patient has subacute to chronic cognitive decline in the form of behavioral changes, and headache may occur in the cases of neurosarcoidosis. But cranial neuropathy and without any history of uveitis, with no pulmonary or systemic sarcoid features, kept the differential lower down the order. The second category of differential we had kept as autoimmune in the form of LGI, Casper2, and NMDAR. Specifically, the points favoring were rapidly progressive cognitive decline in the form of behavioral changes, neuropsychiatric features, visual hallucinations, and subacute to chronic course. But the point against was there was no history of facio-brachial dystonic seizures with no history of myoclonus or any movement disorder at presentation. And headache and fever usually favor infection more as compared to the other etiologies. The other autoimmune we had kept as Hashimoto encephalopathy because of the very rapid deterioration in the form of behavioral syndrome, but no history of any seizures, myoclonus, or any thyroid disease history was not told to us in the presentation. The next we had kept as metabolic cause because the patient is a known case of CKD and he had stopped taking dialysis, which he needed initially twice per week. So could have been uremic encephalopathy. But the point against was it was having a progressive course without any history suggestive of asterixis or any fluctuation in behavior, with no history of any prominent hallucinations, which was very uncommon for this uremic encephalopathy. The lower down the order we had kept as neurodegenerative in the form of DLB, although only the hallucinations are not enough to diagnose a patient of this cadre having neurodegenerative disease, but the cognitive impairment pushed us towards the diagnosis. But the disease progression was too rapid, and headache and fever was unexplained for DLB, and there was no history of any Parkinsonism or no history of any RBD-like phenomena. Neoplastic and vascular, we had kept down the order because of the patient, although was a known case of CKD, but it could have been primary CNS lymphoma with multi-infarct state. But the course was subacute encephalopathy, more predominant as compared to the focal neurological deficits, with headache as the predominant symptom. But points against was no focal neurological deficit with no constitutional symptoms or features of raised ICP. Moving on to the general examination. On admission, we received the patient in drowsy state and he was disoriented to time, place, and person. The GCS recorded was E3, V4, M5, and BP taken in the right arm in the supine position was 150 by 90 millimeter of mercury. Pulse rate was regular, 80 beats per minute, normal volume with no radial radiofemoral delay. Respiratory rate was 18 per minute with predominant abdominothoracic type of respiration, and he was afebrile at the time of examination. JVPF was not raised, but there was bilateral pitting edema, probably due to CKD and anemia as well. However, there was no signs of dehydration, icterus, cyanosis, clubbing, lymphadenopathy, or no history of any palpable or visible thyroid swelling. Moving on to systemic examination, the respiratory and cardiovascular and per abdomen examination was unremarkable, and CNS examination, the higher mental functions could not be done due to poor attention and poor GCS. Cranial nerve, the patient has bilateral symmetrical and pupils and which were reacting to light with no asymmetry noted, and fundus was not having any papilledema, with no signs of any optic atrophy, no ptosis, nystagmus, or any facial weakness noted. Tone motor was normal in all the four limbs. He was able to move all the four limbs against gravity on stimulation. DTRs were 2+, plantars were bilateral withdrawal, and there was no meningeal signs on admission, and skull and spine was grossly normal. So summarizing based on the history and clinical examination, a 60-year-old hypertensive CKD male, who was previously on intermittent hemodialysis, sometimes twice per week, sometimes once per week, and he was not on any maintenance hemodialysis since last 6 months, presented with insidious onset behavioral predominant syndrome in the form of apathy, visual hallucinations, altered sleep pattern, and recent memory impairment for the last 4 months, with history of headache for 1 month and fever for last 10 days, progressing to encephalopathy, which was very rapidly progressive over a period of subsequent 1 month, without any history of suggestive of raised ICP, seizures, myoclonus, any cranial nerve or autonomic involvement. On examination, the patient was afebrile, drowsy, but disoriented to time, place, and person, and having bilateral pitting pedal edema with absent meningeal signs. So based on the history and clinical examination and the differentials, the list we had made, we had started the patient on initial management. The routine investigations were sent before starting any treatment, and we had planned for the lumbar puncture after doing the brain imaging, since it was not available with the patient. And basic medications, as per the CKD, we have started in the form of iron tablets, tablet torsemide, because the patient was in overload on clinical examination, although there was no signs of raised JVP. Calcium and vitamin D supplementation was started, and based on the psychiatric symptom, tablet quetiapine in the very low dose of 25 milligram bedtime was started, with baseline QTC measured was 420 milliseconds. Initial investigations on day 1, as it came, the HB was towards the lower side. It was 10 milligrams. TLC was almost normal, with OTPT slightly towards the higher limit of normal, and the baseline creatinine was 2.3 and urea was 59. NT-TPO and TFT were normal, and chest X-ray was normal on admission. So we had got the MRI done on the very same day, and it was not very much suggestive of typical chronic meningoencephalitis like picture. In the T2 images and T1 images, we could not find any abnormality, but in the T2 flare, we could localize there was asymmetrical dilated VR spaces more towards the left side as compared to the right side, although it was not having any basal exudates or any other classic syndrome like picture. So based on the MRI, we have started with the other investigations, and we had done the patient with the CSF on day 2. The opening pressure was 14 centimeters of water. The color was slightly pale. Total cell count came out to be 240 with lymphocytic pleocytosis. Proteins were elevated, and glucose was on the lower side with corresponding sugar of 75, and CSF glucose was found to be 26. A gram stain, AFB, ZN stain, KOH, and NINC all came negative the next day. And ADA was remarkably high of 48.7 units per liter. Serum ACE came out to be normal. HRCT thorax we had planned the same day, and the next day it came out to be normal. And baseline CD4 counts was 328 cells per microliter, suggesting the mild to moderate immunosuppression. This MTB PCR and CSF malignant cytology was sent along with cryptococcal antigen. It was awaited, and VDRL in the serum came out to be negative. So based on the CSF picture, CSF revealed a chronic inflammatory pattern with low glucose and high protein with lymphocytic pleocytotic picture. Based on the clinical history and CSF findings and MRI findings, presumptive diagnosis of tuberculous meningitis was made, and patient, since a known case of CKD, was started on modified ATT with PZIDE of 1500 mg per day. RCNX combination was started, levoflox was started on alternate day, and ethambutol was started in 800 mg dose of alternate day regimen. Injection DEXA was started in the dose of 8 milligram 3 times a day. By day 4, the serum cryptococcal antigen report came, and it came out to be positive. So by day 5, the other reports also came, since the HIV and HCV report came out to be negative, but the patient was HBsAg positive. And for this, the gastroenterology reference was taken. HBV DNA and HBe antigen were advised, but the attendants were not willing for any further investigations. And the meanwhile, CSF CVNAT came out to be negative, and CSF cytology also came out to be negative for malignant cells. In view of positive report of cryptococcal antigen, we started localizing or tracing the report of the CSF cryptococcal antigen, and it came out to be positive on day 5. India Inc. although came negative for the capsulated yeast organisms, but cryptococcal antigen came out to be weakly positive in CSF. So based on this report, we started the patient on liposomal amphotericin B, and ATT and steroids were stopped because there was no clinical radiological evidence to be keep going with the ATT. So liposomal amphotericin B was started in the dose of 3 mg per kg as the standard protocol, but the tablet flucytosine the patient was not affording, hence only the liposomal amphotericin B was continued. And the plan was to continue it for a period of at least 2 weeks as the induction regimen as per the standard IDSA guidelines. Meanwhile, on day 5, the patient had one episode of seizure. It was generalized tonic-clonic semiology with impaired consciousness, and the loading dose of levetiracetam 1 gram IV in the renal adjusted dose was given and continued with the maintenance dose of 250 milligram PD. And the EEG was done the next day, which showed no epileptiform discharges with generalized theta slowing. And meanwhile, on day 7, the CSF culture report also came, and it had shown the Cryptococcus neoformans report, which was urease positive. And based on this, we had the presumptive diagnosis of cryptococcal meningitis confirmed by the CSF, as well as the radiological confirmation was done retrospectively. On day 8 to day 14, this liposomal amphotericin B was continued. And meanwhile, the patient was able to arrange tablet flucytosine, and it was started in the renal dose with the creatinine clearance of about 28 milliliter per minute. So hence the dose of 25 milligram per kg per day was adjusted 12 hourly. So it came out to be 1250 milligram. So we started the patient on that, and serum creatinine and potassium were constantly monitored since the patient was on amphotericin B. And to our surprise, the sensorium improved drastically from a state of E4 V3 M5 to E4 V5 M6. Meanwhile, the investigations from day 1 to day 15 were almost similar in trend from as per the baseline investigations, with creatinine starting from the range of 2.3 to 2.7 and then coming back to 2.3, and blood urea was slightly on the rising trend, but urine output was constantly monitored, and the patient had been maintained on the urine output of about 1.5 to 1.9 liters per day constantly. So by day 14, liposomal amphotericin B was stopped as per the protocol, and tablet fluconazole was started in the consolidation phase with renal adjusted dose of 800 milligram per day, along with flucytosine 1250 milligram twice daily was continued. And patient, meanwhile, since he was in ICU and bedridden, he was continued on thromboprophylaxis based on the creatinine clearance of 28 milliliter per minute, and enoxaparin was started on 30 mg once daily subcutaneously dosed. Day 19 to 25, the constant monitoring of electrolytes was done since the patient was improving with no dip in GCS. Antimicrobial therapy was continued in the form of flucytosine, and antifungal therapy was continued in the form of fluconazole. The patient was in consolidation phase at this time, but here the patient started having hyponatremia from day 19 onwards. Although the other blood parameters were almost constantly in the same range with no liver enzymes raised, the serum sodium started falling from 124 to 122 on day 25. Similarly, the creatinine had almost a similar trend, with urea having the similar trend in this format. Urine output was constantly monitored, although it was normal. So based on the suspicion of the cause of hyponatremia, we started suspecting cerebral salt wasting versus SIADH. Since the patient was euvolemic, so cerebral salt wasting was almost out of the picture. We sent the patient's urine for electrolytes and osmolality, and it came out to be normal. So SIADH was also ruled out. Then the third possibility, we suspected that since the patient was on liposomal amphotericin B, so it could have led to the renal injury, which could have led to the loss in the which could have led to the decrease in the serum sodium levels. But the urinary electrolytes were in the normal limits, and the patient was not having any kind of hypokalemia or hypomagnesemia, so that was also seemed to be less likely. So by day 25 to day 30, the patient, although sensorium was full, there was no deterioration. So we preferred oral salt supplementation, and the other investigations were almost in the normal range. So investigations from day 26 to day 30, the patient had improvement in the serum sodium from 122 to 126 to then later on day 30 as 129, with OTPT was in normal range. This bilirubin was in normal range. There was platelets were slightly in the lower normal range, and creatinine and urea was almost stable as per the baseline. But on day 30 in the evening at around 8 p.m., patient went into bradycardia. Patient went into tachycardia and hypotension. BP was recorded at that time to be 70 by 50 millimeters of mercury, with GCS dropped from 15 by 15 to E2, V1, and M4. Although the chest was clear, we had a rapid search for the cause identification. The patient was not able to maintain the oxygen saturation on high flow oxygen mask, and hence he was intubated and put on ventilatory support. We started the patient on inotropes and IV fluids. ECG suggested of sinus tachycardia. Bedside 2D echo was done. It was not having any signs of right ventricular stain or any right ventricular wall, free wall hypokinesia. So hence the signs of the overload was also not there. Cardiac profile was sent and D-dimer was also sent. And this was the ECG of the patient at that time. It suggested sinus tachycardia with no other signs of RV stain or any signs of PE. But on day 30 at around 9 p.m., the patient heart rate dipped. It was about 32 per minute with GCS drop further to even BTM1. Although the chest was clear, injection atropine was given. Cardiac profile by the time came negative. Although the D-dimer was found to be raised with the value of 1.62 with normal values of about less than 1.5 microgram per ml. The patient developed cardiac arrest after a period of 20 minutes. CPR was given, but patient could not be revived. Looking on retrospectively, the ABG remained within the normal limits throughout the hospitalization with no evidence of any respiratory or any metabolic acidosis prior to the terminal event, with no reduced urine output suggesting the renal injury, either drug induced or the worsening CKD. So based on the deterioration from GCS 15 by 15 to 3 by 15, and there was a sudden dip and sudden hypotension with tachycardia. So based on this finding, presumptive diagnosis and also the D-dimer was raised, presumptive diagnosis of pulmonary embolism was kept as the immediate cause of death. The cause, antecedent causes leading to cryptococcal meningitis, since the cryptococcal meningitis predisposes the patient to prothrombotic state, and hence it could have led to the pulmonary embolism with the antecedent comorbid condition of chronic kidney disease causing it, and the other significant conditions contributing to death could be hepatitis B. So the overall course of illness from day 0, the patient was admitted in the hospital with altered behavior, visual hallucinations, and forgetfulness. Then on day 2 of admission, the CSF was done, which suggested the chronic meningitis picture of lymphocytic pleocytosis with with this low blood sugar, low CSF sugar with corresponding normal sugar. And based on this, the ATT was started. But on day 4, the serum CRAG report came out to be positive, and on this premises, we started the patient on liposomal amphotericin B, and the patient's GCS improved from 12 by 15 to 15 by 15, and we kept the patient on induction regimen followed by consolidation regimen, and he was improving with the development of hyponatremia from day 19 onwards, which was managed with IV fluids, and inotrop, which was managed with IV fluids and oral salt supplementation, and patient was on improving course. But suddenly on day 30, the patient went into bradycardia, tachycardia, and hypotension. And along with that, he was not resuscitated by IV fluids and inotropes, which led to the mortality. So why was this case challenging? Because unlike the normal presentation of cryptococcemia, the patient had not been presented to us with the history of fever and neck signs or any cranial nerve involvement. Rather, he presented to us with rapidly progressive behavioral changes in the form of neuropsychiatric manifestations with only 10 days of fever, and despite 4 months of prior neurological worsening, where there were no meningeal signs on admission, without any cranial nerve involvement, with almost near normal MRI, with no signs of any basal exudates, with few prominent VR spaces, and the patient was retro-negative, although he was a patient of CKD with relative immunocompromised state, with neurological improvement was there with antifungal therapy followed by sudden fatal deterioration.
Yeah. So in this case, go back to the slide, Dr. the previous slide. So this was obviously challenging. Like this was one case where the patient came with that syndrome of rapidly progressive dementia without any meningeal signs, without any focal deficit as such, other than obviously the encephalopathy. It was not, obviously it's a generalized encephalopathy, near normal MRI. And patient was labeled as CKD, and he had got his last dialysis some 1.5 years back, and he was although he was lost to follow from the nephrology OPD, but he was maintaining his creatinine. The last records clearly told that, clearly suggested that the creatinine values were quite stable. So obviously, because of the rising creatinine and stable creatinine of 2.4 and maybe slightly shrunken size, he was labeled as CKD, but he did not require, he was not on maintenance hemodialysis. Other than that, there was nothing which would suggest other than the CKD. We did not have any other features which could suggest that he is relatively immunocompromised, right? So this was a case where there was no meningeal signs, no focal deficit, no cranial nerve deficit, no other signs of faculty other than pure rapidly progressive dementia in an elderly male. And this is what we had at an offering. At the hind end, when on the first day of admission, when we started the patient on based on CSF pleocytosis, we started the patient on ATT with steroids. Steroid, maybe it had a red herring, we do not know, right? So the role of steroids is obviously a bit, I mean, we got the report on day 4, day 3, day 4, where we stopped ATT on day 4. By day 1 to day 4, the patient was on ATT and dexamethasone. So that at the hind end, when you start thinking over it, so probably steroids are, and thinking of when we think of tubercular meningitis, we obviously supplement with the patient with steroid. But in this odd case, patient had taken steroids for 4 days. By the end of 4 days, we had to, obviously, when we had the report, we stopped it, right? So Dr. Chamanjot, any comments?
Yes, sir. So retrospectively, I feel when we have such a CSF report, which is suggestive of meningoencephalitis kind of a picture, we are very right in starting the ATT. We have to start. I mean, we don't
Right.
have any other report that is favoring anything else. I think one thing that could have been done is we could have waited for steroids part.
Yeah.
I mean, until we had the report of cryptococcus being positive
Yeah.
or negative, I think then we would have taken the decision of steroids. Rest,
Yeah.
I feel, this is how we would have approached.
Right. Right. Any questions from the attendees, the listeners? Any comments? You can please drop in the chat box. There are none as of now. So, Dr. Anand, go ahead, please.
So that brings us to the point that what are the key differences so that by these points we can diagnose the patients, especially in younger adults in comparison to the older adults. Do they have any difference in the presentation, in the basic presentation at the time of presentation? So yes, as the literature says, the patients who are younger adults, they usually present to us with the headache, with fever and neck stiffness. However, if we go to the elderly population, the chief presenting symptoms are usually the altered mental status, behavioral and cognitive decline, and memory impairment. And particularly, these have been seen in the literature in non-HIV elderly, although the HIV elderly, they would have the immunocompromised status. These differences should be kept in mind.
And this should be
So
highlighted. I mean, this is the highlight, how
yes.
elderly present, right? So it's all behavior, memory, and altered mental status. You see the percentages, it clearly outnumbers. So you don't need to show the statistical difference, but obviously the numbers clearly says that the older adults will have this dementia-like picture, as we call, right? Rapidly progressive dementia, as our case had. So clearly the mental altered mental status, behavioral abnormality, cognitive decline, the memory impairment, this is the presentation that normally elderly can have, even with cryptococcal meningitis, without any cranial nerve deficit, without prominent headaches, without fever, right? So the percentages vary from 30 to 55%, talking of fever. But obviously we all know at the extremes of age, even in children and in elderly, in all the classical infective cases, they will not classically present to you with, say, fever and headaches, right? So that is a take home message, and take home probably the point that the attendees can take away is, you for the extremes of age, especially in elderly, the classical infective picture might be missing, right? As in this case. Go ahead.
So the point here to be highlighted is, since as I've already told, the opening pressure of the CSF was 14 centimeters of water with no signs of raised intracranial tension, and this should be emphasized very strictly that in older adults, usually there are no signs of raised intracranial ICP with minimal headache or fever, and usually they will have hypersomnolence, memory impairment, and behavioral kind of changes. On the contrary, the younger patients would have cranial neuropathies and signs of raised intracranial tension. So evolution of treatment in cryptococcal meningitis, there are two school of thoughts. One was the before 2018 era, and there was two landmark trials. One was the ACTA and the other was Ambition CM trial. But the point here was these both were done in the patients who were HIV positive. So there are very minimal RCTs which are done in the patients who are retronegative. So in 2018, there was a trial named ACTA which compared the 1 week amphotericin B with plus flucytosine, and it was compared with the 1 week fluconazole treatment. On the other hand, there was 2022 landmark trial, which was Ambition CM trial, in which the single high dose liposomal amphotericin B in the dose of 10 mg per kg, along with 14 days of flucytosine plus fluconazole was given, and it was proved to be non-inferior to the other treatments. Hence, it was a treatment-changing trial. So the current IDSA guidelines, which was updated in the year 2024, was divided into two settings. One was a high resource setting, the other was the resource limited settings. The high resource setting preferred the induction regimen from amphotericin B in the dose of 3 to 4 mg per kg per day, 10 days, which we had followed by flucytosine in the dose of 100 mg per kg per day. And actual dose is 120 mg per kg per day, but we had adjusted the renal dose of the patient. So hence the dose was adjusted in our patient, followed with fluconazole in the form of consolidation regimen for going up to the 8 weeks. And based on the CSF reports as well as the repeat MRI picture, it can go up to a period of about 6 to 12 months as well. While in the resource limited settings, the preferred induction is a single dose liposomal amphotericin B in the higher dose of about 10 mg per kg, and followed by flucytosine in the dose of 100 mg per kg for a period of 2 weeks, followed by fluconazole 1200 mg per day for a period of 14 days. These are the landmark cryptococcal meningitis trial. I have divided it into two sections. One was in the retro-positive patients, the other was in the retro-negative patients. There were only a few trials which are done in the retro-positive patients. These are the trials which compared amphotericin B plus flucytosine with amphotericin B alone. And most of the trials, they have established that the combination therapy is a cornerstone in the management in the initial induction regimen, because of being treated as a life-threatening condition, and if not treated promptly, would have neurological sequelae and consequences. The point here to be emphasized is the Ambition CM trial, which was done in 2022. It was highly relevant to HIV positive hosts, not routinely extrapolated to the non-HIV immunocompromised patients like ours, who was diagnosed as CKD from outside. Non-HIV cryptococcal meningitis, the evidence which we have, only a bunch of case reports and the expert reviews from the year 2019 onwards only. We don't have any randomized control trials. The only randomized control trial which is currently ongoing is comparing the two major treatments in the form of liposomal in the dose of 1 mg per kg to this conventional amphotericin B in the dose of 0.7 mg per kg, but it is still ongoing. The results are in phase 2 trials, phase 2 currently. So in the non-HIV, the level of evidence is moderate, but all the consensus and the expert or the case reports, case series, they suggest the combination of treatment of amphotericin B plus flucytosine as compared to the single therapy. So I have tried to search for the literature. We have found the various case reports of reversible dementia, a case of cryptococcal meningitis masquerading as Alzheimer's disease, and some has reported as the cryptococcal meningitis misdiagnosed as Alzheimer's disease, because the patients in elderly would present as the behavioral syndrome as the initial presenting symptom, which would later on be evolving into the headache and this fever kind of pathology. So predictors and long-term outcome of seizures in human HIV negative cryptococcal meningitis. This research article denotes that if the patient who were even having a single episode of seizure would have the worst outcome and longer need of hospitalization in comparison to the patient who were not having any episode of seizures. Similarly, the other studies which had compared the retro and retro negative patients all have emphasized the combination therapy and the initial approach towards the diagnosis of the patient and high index of suspicion in order to have the diagnosis early and start treatment as early as possible in order to prevent the further neurological consequences. So early clinical and microbiological predictors of outcomes in hospitalized patients with cryptococcal meningitis. And this article concluded the age and CSF yeast count were independently associated with in-hospital mortality of the patients more in those patients who were elderly as compared to the patients who were younger. So this article had a retrospective pooled analysis in the patients ranging from the year 1980 towards 2015, and we can all see the number is constantly rising from 0.158 million to 2.8 million in the patients, and it is seen more in the patients who are having CKD as compared to the patients who are non-CKD because of the relatively immunocompromised status. So the take-home message from this presentation is we first of all we have to have the high index of suspicion, not merely based on the clinical presentation of not having the signs of raised ICP and based on the CSF findings only. It needs multidisciplinary care, and it is always beyond the antifungal therapy and managing the raised ICP. The electrolytes need to be looked for, and there should be high index of suspicion in order to prevent the further consequences, and monitoring of renal dysfunction and drug toxicity and the drug levels are of utmost importance. The current regimen of Ambition CN and ACTA trial and IDSA guideline of 2024 focuses on resource limited and resource yield settings from high dose single liposomal amphotericin B along with combination flucytosine to a resource limited setting of this single dose 3 to 4 mg per kg per day dose for an induction regimen of 2 weeks. Early recognition holds the key because shock requires immediate resuscitation. Pulmonary embolism may present even with the isolated sinus tachycardia as the only presenting symptom, with rapid evaluation needs to be focused on. And the clinical lesson here is maintain the vigilance for systemic complications throughout the hospitalization even when the neurological status of the patient improves. Successful outcome depends not only on the effective antifungal therapy, but also on the early recognition and prompt management of life-threatening systemic complications. Thank you.
So thank you, Dr. Anand, for beautiful
So
presentation.
ultimately,
Yeah, go ahead, Dr. Chamanjot.
so ultimately, what this case actually teaches us, this patient came to hospital, he was diagnosed with meningitis, cryptococcal meningitis, but his infection was not the cause of his death. His infection was managed appropriately. He was getting his GCS was getting improved. He was doing pretty. But the cause of death is the complication arising from this cryptococcal meningitis. So it is important for us to look back. We are not only to treat the infection part, but also we have to cater to the prophylaxis, to the prevention part of the complications, as was done in this patient. He was very well given the prophylaxis, he was given enoxaparin according to creatinine clearances. He was done, everything was going fine, but I had some doubt at what point should the prophylaxis part be reassessed, or when we should be, hiking up the dose of prophylaxis. Because to me, it looks like patient succumbed like within 1 hour.
Yeah.
It must have been something very massive, or massive thromboembolism must have happened, which led to his ultimate demise. So are there any parameters we can, reassess our prophylaxis part?
Yeah, very pertinent question, because the likely cause that appears out here is obviously pulmonary embolism, and he was already on the prophylactic doses. So probably maybe a bedside Wiener Dopplers, maybe the serial evaluation of D dimers where we see some rising trend. We could have seen some rising trend where we could have taken a decision. Maybe, I mean, in a rising trend, maybe we could have obviously when patient deteriorated, he straight away went on ventilator. So CT angiography, and he gave us no time for intervention and the thrombolytics. So probably a very pertinent question in this high risk these high risk cases. Probably we need to be more astute and more methodical at bedside examination, and the biomarkers like D dimer. Maybe we are not very sure on whether there is some data where the rising titers do correlate with it, but probably that would have helped. Maybe a bedside ultrasound with the Dopplers might have given us some suggestion, and we could have gone on to therapeutics, and maybe we could have investigated with CT angiography. So yeah, these are very pertinent questions, and we need to look into the data and the studies. Are there any which would have which could have guided us on how, the prophylaxis part? So a very pertinent question. Yeah.
Yes, sir. Yes.
So the house, if the house does have any question, if they have, please put in the chat box. Chat box was obviously empty throughout the presentations, So it's still empty now. So Ela, over to you. Ela, are you there? So Ela is not there. So anyways, I think if there are no more questions, me and Dr. Chamanjot, thank you for all of us, for all of you who joined us, and a very beautiful presentation from Dr. Anand. So thank you all.
Thank you.
Thank you all. Thank you, Dr. Anand, for this presentation.
Thank you. Ela, have you joined back? So, no issues. So thank you all. We can leave now.
Thank you.